Thanks to the organizing team of first ever midterm meet of UPSI, UPAMASICON, and especially Dr. Shubha Agrawal, Professor Prabol, Professor Anubhav for according me this opportunity to be here in front of you today. The topic anatomy of the anterior wall is so vast that the details can easily fill up chapters or even books, and 12 minutes is a woefully short time. So I decided to skip the mundane details about the origin, the insertion, the attachment, anatomical courses, and the present day focus on the exotic Propsalis fascia. Instead, I picked up a few nuggets of information which are either missed in the routine discussions or not emphasized enough. In the treatment of abdominal wall hernias, including inguinal hernia, an apt analogy would be the choice between locking the doors of an open garage or constructing a wall in front of a garage with the doors left open to prevent the car from being stolen. Now, even today, the gold standard remains construction of the wall like in Lagenstein's repair, but leaving the doors open. But fortunately, with the thought process which started with the pre-peritoneal Rives-Topaz approach, the major focus in all anterior wall hernias has shifted to understanding and then managing the peritoneal hernial sac, right at the door level, that is at the pre-peritoneal space, and the defect in the transalus fascia. The highlighting of transabdominis, fascia, transalus, and peritoneal tissue is to highlight the fact that now the major understanding of the genesis of hernia and how to treat and prevent hernia formation resides in these three important layers: the transabdominis muscle, the transabdominis fascia, and the extraperitoneal tissue. Not to say that the muscles are not important, the crisscrossing external oblique and internal oblique, and the longitudinally lie and the transverse abdominis, and of course the longitudinally lying rectus abdominis all have a major role to play in the function of the abdominal wall and of course prevention of hernia formation. Based on these muscles, we can now talk about the vectors of force on the abdominal wall. So the total vector effect is in two directions, the vertical and the transverse direction. And we know that the force in the transverse direction reportedly twice as much as the forces in the longitudinal direction. And contraction of the rectus muscle does not promote hernia formation. Contraction of external oblique muscles, internal oblique muscle, transabdominal muscle, they all pull the rectus apart. Based on the Pascal's law, the abdomen acts like a container, a round container, and any increase in the intraabdominal pressure is equally distributed all around the ventral abdominal wall and of course the lateral abdominal wall. But the maximum is on the linea alba, and because the weakest link, that is why the formation of hernia is most common in the midline or paramedian. Now, the vertical incisions have a higher risk of hernia than transverse oblique incision. That is the net result, or that is the net message based on the vector forces. The vertical midline incisions are the most to blame. They have the highest incidence, more than even the paramedian incision. The upper abdominal incisions are more susceptible to hernia than lower abdominal incisions. Surgical update 2023. Midline vertical incisions, they do give a maximum amount of exposure in terms of content. That's why one of the best incisions for emergency laparotomies is fast, and the most appropriate method to prevent hernia formation in the postoperative period is to close the abdomen with a slowly absorbable suture in the ratio of 4:1 based on the length of the suture line and the length of the suture, and they should be small bites of 5 to 8 millimeters. The paramedian incisions, which are better as far as the ventral hernia is concerned, they have the downside of being both time consuming, limited exposure. Rectus split causes denervation of the medial segment, so muscle retracting is better, but even in muscle retraction it is always susceptible to excessive retraction and leading to damage to the epigastric vessels, and that's why the paramedian incision has its own limitations. The transverse incision is the best, gives the best incision as far as the languline is concerned, but the downside is the exposure is a minimal among these three incisions, the midline, the paramedian, and the transverse. The transverse incision has got the minimum amount of exposure. Now, let's talk about the rectus abdominis and this is the only vertical abdominal muscle along with the pyramidalis, and it is converted into either 4 or 5 segments on each side depending upon the interstices, and these are the fibrous intersections which convert it into small muscles, and these small muscles, they contract individually and progressively, and they obviate the bowstring effect of a long muscle. If these intersections had not been present, then this long muscle would have had a bowstring effect which would have been absolutely useless action. And that's why the conversion into small segment, it along with the external oblique and the other abdominal muscles, it helps in tensing the abdominal wall, graded flexion of the trunk, stabilizing the pelvis, and aids in childbirth, defecation, micturition, and forced expiration, among others. And in this context, diastasis recti needs to be defined, and we all know that diastasis recti is when the distance between these two medial ends of the rectus abdominis is more than 2.7 centimeters. And that is when we call it a divarication of the recti, and that may require treatment. Talking about the rectus sheath, you look at the rectus sheath, we all know how it is made, but what I would like to highlight out here is that the transverse abdominis in the upper third is extending below the posterior surface of the rectus sheath, and that's why the linea semicularis is formed only by the external oblique, the internal oblique, and the lateral rectus sheath. That is what forms the linea semilunaris. The transverse abdominis does not play any role, or it does not contribute to linea semilunaris. And the fiber extend more medially. But as it goes down, as we go down, we find the transverse abdominis muscle is retracting, or is receding, I would call it, more laterally. That means the muscle fibers, they recede more laterally, and a more fibrous part gains access to the midline. In the lowermost part of the rectus sheath, you have the semicircular line or arcuate line. Now, the rectus sheath with its anatomy and applied, the width of the sheath is very important. Midline to semilunar line is the width, the extending from the midline to semilunar line. And what we know now from studies is that in the region of the umbilicus and up, it is somewhere in the region of 6 to 7 centimeters. And that forms a guideline to major procedure now, which is now coming into vogue, and that is the ETP repair, both for ventral hernias and for inguinal hernias. So the both side should be within the semillunaris, and a safe distance is 3 to 4 centimeters from the midline. What about the cranial extent? Because we want to gain a more larger preparietal space, so we try to take this incision supraumbilically, and supraumbilically about 3 to 4 centimeters. But one thing to be remembered when you position this port is that the distance between this port and the subcostal margin is important, especially lean and thin person, because as soon as you start moving the instrument in this port, it may clash with the bony subcostal margin. And that's why this distance D is important. But otherwise, the safe distance is about 3 to 4 centimeters laterally and 3 to 4 centimeters cranially. But remember, it can be positioned anywhere in this purple area, But as you go down, the preparietal space accessibility decreases. It can also be positioned in this area marked by the black squares, but the problem in this black square area is that here the chances of injuring the peritoneum is very, very high, because within the semilunar line, you got the posterior rectus sheath to prevent injury to the peritoneum. Here you don't have anything to prevent injury to the peritoneum. It's just the transalis abdominis muscle, underneath which is the transalis fascia. As soon as you go beyond this muscle, there are very high chances of injuring the peritoneal layer. Now, the thickness also makes a difference, and the usual thickness of about 10 millimeters, and in those who are manual workers or athletes, it can go right up to 20 millimeters. And this is important in the sense that when you take this port and you go obliquely, you enter up to the posterior rectus sheath, then you have to take a transverse course until you reach the arcuate line. And as soon as you reach the arcuate line, there you have to transect both layer number 1 and layer number 2 transverse abdominis fascia before you can enter into the preperitoneal space. So the thickness is very thin in lean and thin person. That's why in those person, it is very easy to damage the posterior rectus sheath. Once you do that, you damage the peritoneum, right? So the course of the trocar is very important. The oblique, the absolutely horizontal parallel to the rectus, the posterior rectus sheath, and then again oblique. Now, what more do you need to remember about the rectus sheath? Number one, the rectus sheath hematomas are cause for unexplained morbid hypovolemia for the reason that once the epigastric vessel starts bleeding, it takes the easy course out, and that is the preperitoneal space. And because the preperitoneal space is an easily expandable space, diagnosing a hematoma lying in this space is very difficult. So the diagnosis becomes late, and the patient goes into hypovolemia. So, number two, the posterior sheath is closely opposed to underlying transverse fascia, as we already stressed, and it both acts as a cushion. And as soon as you damage the posterior rectus sheath, 100% time you will have a peritoneal damage and pneumoperitoneum. So that is important to remember. Number three, the use of the sheath for rectus sheath block, which gives a very good midline analgesia and to a certain extent muscle relaxation in the midline. And here the local anesthetic is infiltrated in between the posterior wall of the rectus abdominis muscle and the anterior surface of the rectus sheath. Another thing to remember is transecting the sheath for creation of large preperitoneal space, as is done in ETP for ventral hernia or inguinal hernia. It should always be 1 centimeter at least lateral from the linea. If you don't do that, you're going to damage the linea, and then you have to stitch the linea back. So to prevent damage to the linea alba, always transect the medial end of the sheath about 1 centimeters from the midline. Number two, once you have mobilized the whole of the posterior rectus sheath, it also helps in primary facial repair, ventral hernia repair, and ventral hernia management. And over this repaired posterior rectus sheath, you can easily put in a retrorectus onlay mesh. Now, coming to the arcuate line, it does not have any fixed position, but most commonly it is found at roughly 1/3 of the distance from the umbilicus between the pubo-umbilical line. That is the most common site, but it can also extend to varying distance, even up to the pubic bone in certain instances. The usual marking, the surface marking, would be the fourth tendinous intersection if it is present. If it is not, then usually about at the level of the anterior superior iliac spine, that transverse line, up to 3.5 centimeters cranial to it. Anywhere in this belt, you can have the ending of the arcuate line. Now, why are we worried about the arcuate line? What about the arcuate line? It's important because there could be 3 types of arcuate line. And unfortunately, the most common type found in 65% cases is an arcuate line where it usually merges. See the merging, there is no definite arcuate line out here. A merging of the arcuate line with the transversalis fascia. So here the problem comes where to transect so that you enter into the preperitoneal space. Because if you transect the posterior rectus sheath, you create a pneumoperitoneum. If you transect the transversalis fascia, you enter the preperitoneal space. So here identification becomes a problem. Unfortunately, the most common, the less common type, which is the most desirable type, is where you see a very sharp arcuate line as seen out here in only 25% of cases. This is the type 2 arcuate line, and you can easily see the loose preperitoneal space. Once you enter to the transversalis fascia, layer number 1 and layer number 2, you enter into the preperitoneal space. The third type, found only in 10% of cases, is where there are multiple arcuate lines or multiple thickenings in the posterior sheath, which mimic multiple arcuate lines as seen in this photograph. So, what is the applied importance? Why are we so worried about the arcuate line? For the simple reason, number one, as I said earlier, it defines the first time entry into the preperitoneal space and prevent a pneumoperitoneum, possible injury to the peritoneum. That's very important. Number two, this is the site where the inferior epigastric artery is going to climb onto the sheath after perforating the first layer of transversalis fascia. Remember, the inferior epigastric artery is lying between layer number 1 and layer number 2. So, if it has to climb into the posterior sheath, it has to perforate layer number 1 and then go into the sheath. It is also a junction with the Spigelian line. Its junction with Spigelian line marks the most common site for Spigelian hernia. That means we show it in the next slide. The intersection between the arcuate line and the semilunar line is the area where you get most commonly the highest incidence of Spigelian hernia. It also demarcates the site for cutting the medial or the lateral edge. So if you're going to cut as you're going to enlarge the pupillary space, you start the transection of the rectus sheath from the arcuate line cranially. Harvesting the rectus muscle also is very important. It should always be done only cranial to the arcuate line. Why? Because then the muscle would be, you have harvested the rectus abdominal muscle. So what cushions the or what guard the anterior wall is only the remaining posterior rectus sheath. So that forms a layer which prevents hernia formation. The muscle is no longer there. But below the arcuate line, if you harvest the rectus abdominis, you don't even have the posterior rectus sheath, which can prevent a formation or which can prevent the weakening of the anterior wall. Coming to the Spigelian narrative, what needs to be remembered is the Spigelian belt. We have already talked about the Spigelian line, also known as the linea cerebrosalis, and the Spigelian fascia is the unfused aponeurosis. Remember, the unfused aponeurosis or transverse abdominis and the internal oblique located between the lateral edge of the rectus abdominis and the semilunar line laterally. Right? So this is the Spigelian fascia. You see the Spigelian fascia out here. The belt is important. Why? Because this is the area where you find the maximum incidence of Spigelian hernias, and even among this whole belt, it is at the intersection of the arcuate line and the Spigelian line where you find the maximum number of Spigelian hernias. The belt extends 6 centimeters cranially from the transverse line across the antesupplex spine. So by the side, 6 centimeters cranial to this is the area which is the Spigelian belt, for the simple reason that this is the area where Spigelian hernia is most commonly seen. Now, the hernia is through the transverse abdominis and internal oblique. The external oblique does not have any role to play, and that is why any weakening until a very late stage is hidden or masked by the external oblique aponeurosis. And that's why the most common presentation of Spigelian hernia is either the occult hernia, or later when this hernia tries to grow, it grows interparietal. That means in between the muscle. So there are two presentations of Spigelian hernia. One is the occult hernia, less commonly interparietal hernia, and even less commonly is obvious swelling at the lateral edge of the rectus abdominis muscle. A few words of the abdominal wall vasculature. When we talk about the vasculature, you can easily divide it into the superficial vasculature and the deep vasculature. And if you look at the deep vasculature, you've got the epigastric vessel, the superior and the inferior, and then you've got the thoraco-epigastric artery, or the musculophrenic artery, which is the lateral branch of the internal mammary, and you've got the deep circumflex iliac. So these four are the major vessels. Along with that, you've got the perforator of the subcostal and the intercostal vessel. They all together make the deep vasculature which is supplying the muscle, and they are lying in between layer number 2 and 3, that is the internal oblique and transverse abdominis muscle. Compare this with the superficial vasculature, which is usually the perforators arising from these vessels, number 1, and the 3 important vessels arising from the first part of the femoral artery, namely the superficial epigastric, the superficial circumflex iliac, and to a certain extent the pudendal. So these are basically the vessels which are supplying, and then across are those perforator vessels from all the deep vessels which supply the abdominal wall. Now, this vasculature, for the sake of abdominoplasties, has been divided into 3 zones, and these 3 zones are known as the Hugo's vascular zones. And why have they been divided into zones? Because each of the zones has got its own specific artery, and these are composed of angiosomes of the source vessel incorporated in each vessel, in each zone. So the source vessel in each zone is different. The zone 1 from the xiphisternum to the ASIS is basically got the source vessel of epigastric vessel. The zone 2, which extends between the groin and pubic creases and the ASIS, has got the superficial epigastric, the pudendal, and the superficial circumflex iliac vessel. And then the zone 3, which is the lateral zone, lateral to the linea semicularis, which has got the perforators and the intercostal vessel. So based on these 3 zones, you've got their own source vessel which incorporates the angiosomes of the source vessel. So angiosome basically means source vessel along with its bone, along with muscle, along with its fascia, and along with the skin which it supplies. So based on this, this is very important when you talk about abdominal grafts, that means the skin graft, or you talk about flaps, not grafts, I'll say flaps, and you also talk about the anterior CST where this vascular zone becomes important. Now, the neurovascular supply of the rectus abdominis is through the infraepigastric vessel, which needs just a few more words. Arising from the terminal part of the external iliac, it climbs into the arcuate sheath, into the posterior sheath at the arcuate line, and then it ascends up and makes contact with the superior epigastric vessel. All the time it is lying stuck under the undersurface of the rectus abdominis muscle. That means at all times lying in between the posterior rectus sheath and the rectus abdominis muscle. That is the plane of the situation. That's where it's situated. And it always leads to, so before it can climb in, as we stressed earlier, it has to perforate the first layer of the transalus fascia. So in addition to this, also give rise to a number of perforators, and these perforators are important, especially in the periumbilical region and the midline. The venous drainage is through the corresponding veins, but what else is needs to be stressed is that these rectusial veins, which are veins draining the rectus muscle, they make contact with the infraepigastric vessel, giving rise to a venous plexus along with the pubic vein, giving rise to a very rich venous plexus known as the plexus of Bendavid, which is situated at this spot, which is known as the anatomical space of Bogoros, which is distinct from the surgical Bogoros space. So you got the anatomical Bogoros space, you got the surgical Bogoros space. These two are different. So we only talk about the anatomical Bogoros space where you got the situation of the Bendavid venous circle. Now, I'm not going to go into the detailed Bogoros space because that is beyond the scope of this lecture. We can talk about it later, or you can look at the on the lecture of transalus fascia already uploaded on YouTube. You have that lecture loaded there, right? Now, coming to the infraepigastric artery, this is situated anywhere between 4 to 6 centimeters or 4 to 5.5 centimeters from the midline. So, taking this and the lateral edge-of-semilunar line or the linea semicularis, both of them when taken together, a safe position of the port would be this area. And that is why, if you remember the previous slide, we said the port is better situated between 3 to 4 centimeters, 3 to 4 centimeters from the midline. That means lying medial to the infraepigastric vessel, right? So when this inferior, see, I told you that the inferior vessel is coming from below and it reaches the undersurface. So it's stuck to the undersurface. That's the inferior gastric vessel. So when you go, this is the posterior rectus sheath seen here. So when you do a ETP, you're running parallel to the posterior rectus sheath, and it is here that you cut the transalus fascia and you immediately enter into the pupetal space. You can cut it here, you can cut it here. Now the space lateral to the inferior gastric vessel is limited. The space medial to the inferior gastric vessel is more spacious. So it is always better to enter the pupetal space medial to the vessel and always lift the vessel up. Dissect the vessel along with the rectus. Please do not dissect in between the vessel and the muscle. If you do that, you have a hanging inferior epigastric artery, and you know hanging inferior epigastric is a big pain, right? Here again the same thing. You see the pupetal space out here. You see the fascia, the posterior rectus sheath, and this is the inferior epigastric vessel which is being lifted along with the rectus abdominis muscle. So please do not dissect in this plane in between the vessel and the posterior rectus surface. Coming to the venous drainage, this again two large veins from above, the superior epigastric and the lateral thoracic or the musculophrenic, two large veins from below. Number one, the inferior epigastric vein and the deep circumflex iliac vein. These are two. On the flanks, you've got the perforators. You can see the flank, these perforators coming from the intercostal. You got the circumflex iliac vein and accompanying lateral deepness. So along with that, the veins form a rich plexus outstream. And from the inguinal region, you got the superficial epigastric inferior epigastric vein. So you got the deep inferior epigastric, which enters into the rectus sheath, and you got the superficial inferior epigastric, which is supplying the skin up to the rectus sheath and lying over the rectus sheath for quite a distance. And along with that, you got the other veins which are terminating in the femoral vein, that is superficial circumflex iliac and the superficial external pudendal. So together they make the major amount of venous supply out here. Now this venous system, Remember, the superficial inferior epigastric vein is in communication with the deep inferior epigastric vein through its perforator. So, the superficial inferior epigastric vein gives rise to, or from here, the vena comitatus arise from these perforators which are coming from the deep inferior epigastric, and that makes the contact between the superficial system and the deep system. And why is it important? It is important because the flow is always from the superficial to the deep and from the cranial to the caudal. That means it is always away from the umbilicus, number one, and it's always away from the skin to the deeper layer. Having said that, what is also important is that the superficial inferior epigastric vein has a rich network in the midline and periumbilical. Why? Because they are crossover veins which communicate with the opposite side. So a large medial branch crosses the midline. In some cases, additional midline crossover points, and which could be infraumbilical or midline or supraumbilical, and they make contact with the opposite side. And that is why, if you look at the infraumbilical part of the midline incision, you'll always find it bleeds more than the supraumbilical part of the midline incision. The branches are multiple throughout its courses, and they all make contact with the other vessels we just now showed in the last slide, and that leads to a very rich network of uh, perforator. So if you look at the applied part of the vascular anatomy, number one, you have a midline and paramedial perforators, not only from the arteries. This is the arterial perforator. See, this is the epigastric vessel lying between the rectus abdominal, the posterior rectus sheath, gives a perforator, perforates the anterior rectus sheath and comes to lie in the subcutaneous tissue. That's the arterial perforator. Along with that, so more perforators from superior epigastric and the lateral thoracic and the intercostal vessel. This is how the perforator perforates the anterior rectus sheath and enters into the skin. But along with that, you also have the perforators from the vein that we just now talked about, superficial vein and the communicating vein. So if you have a rich network of venous plexus and arterial plexus, rich network in the midline and the periumbilical, what needs to be remembered is that skin undermining the periumbilical region should be kept to a minimum. Why? Because if you are leading to excessive undermining of the skin on either side, especially on the medial side, then you lead to devascularization of the flap and damage to its vessel supply. Do you have any clinical reflection of that? Yes. It's supported by the fact that if you see a superficial surgical site infection and midline incisions, you'll always find the umbilicus to break first. You'll find that the umbilical sutures are the first to break out in any midline SSIs. Early umbilical blackening after too much umbilical undermining is again a point in favor of uh, uh, preventing excessive skin undermining in the periumbilical region. Another important part about applied part of the skin undermining periumbilical region is that the curve of the incision around the umbilicus should be performed on the left side of the midline. That when you're giving a midline incision, you have to curve your incision. You can't transect the umbilicus. You have to curve around the umbilicus. So when you're doing that, when you curve around the umbilicus, you should always curve it on the left side. That means the curve should be on the left. In order to spare what? Number one, falciform ligament, and to avoid bleeding from the midline infraumbilical veins. For ACST, that is anterior component separation technique, the lipocutaneous flap creation, you are creating a lipocutaneous flap, damages to the perforator spells doom for this flap. And that is why now what is preferable is what is known as the periumbilical perforator sparing ACST, also known as PUPS ACST, or you can do endoscopic ACST where the perforators are not damaged to that extent. Now, the nerves, what about the nerves are anterior wall? Except for the iliohypogastric ilioguanal nerves, all the nerves, as soon as they leave the quadratus lumborum, they come to lie in between the trans abdominis and the internal oblique. So you can see the nerve lying over the underlying trans abdominis muscle. So this is the plane, and that is the plane in between the internal oblique and the trans abdominis, and that is the prohibitive territory for dissection. Please do not dissect in between the trans abdominis and the internal oblique muscle. And these nerves then enter. See, these are linea superficialis. they enter the rectus abdominis muscle from its undersurface or the posterior part. Above the antesupialic spine, as I said, iliohypogastric ilioguanal nerve, they do not always lie in between internal oblique and transabdominal. Why? Because at the region of the antesupialic spine, they perforate the internal oblique and then they come to lie in between the external oblique and the internal oblique, as we all know from our knowledge from the anterior inguinal anatomy. So, based on this information, transecting the posterior rectus sheath 2 centimeters away from the semilunar line prevents injury to the segmental supply to the rectus. So, if you have to transect the arcuate, transect it here, the arcuate and the posterior sheath, transect it here. If you do it more laterally, you'll cut the nerves. Number 2, the plane in between the internal oblique and transabdominis, we already said, is a prohibitive territory for dissection. But what can be done in this area is it is utilized for, it is now very commonly utilized for the transabdominis block. The fact that these nerves are lying in between the transabdominis and the internal oblique, any local infiltrated in this layer is going to numb these nerves, and that is what is the base of transabdominal block, usually preferably given in the posterior lumbar triangle, and it leads to a better analgesia and a better relaxation than the rectus abdominis block. Now, the anteabdominal wall, as related to the neurovascular structures, see, this is the external oblique and the vessels are lying here. Now, what about the supply to the external oblique? It always enters from the lateral end. And that is why when you're doing a mobilization in anterior component separation, it is always done in between the external oblique and the internal oblique. This is the plane where the mobilization is done, right? The cut is made about 2 to 3 centimeters lateral to the linea submodularis. Now, how far can you go laterally? You can go safely up to the antesupialic spine, because if you go beyond that, then you're going to damage the nerves which are entering the external oblique from laterally, the vessels and the nerves from laterally. So remember, that is a safe limit of mobilization in for anterior component separation technique in between the external oblique and the internal oblique, that is the anterior axillary line. Now, ACST achieves a medial advancement from 3-5-2 centimeters unilaterally, starting from epigastrium, umbilicus, and pubic bone. And I said earlier, because see, this whole flap is being mobilized. This whole flap is being mobilized here, so it's always preferable, and the perforator is coming from here. So it's always better to do a PUPS ACST or endoscopic ACST. What about the posterior CST and TAR? So this is the posterior CST. I think a better depiction would be available in the next figure. And if you look at this figure, see the rectus abdominis, the 3 muscles out here. So you're doing just a plain and simple posterior CST. You cut here. This is the posterior rectus sheath. You cut here. See, this is the transection and just mobilize. That is a posterior CST. But once you go through this layer and enter in between the layer of the fish transalis peritoneum and the transabdomen, this is the plane. If you enter this plane, then you are doing a TAR procedure. So when we said about the neurovascular bundle entering the rectus, this is the undersurface of the rectus muscle. There is a posterior rectus sheath. This is a TAR incision, and this is preferably modified in the sense if you give it slightly more medial to this, that means the green one, that is the Madrid modification, because here then you would not be injuring these nerves, and underneath the transverse abdominis fibers, part of it would be mobilized medially. See, these are transverse abdominis fibers. So be slightly more medial from the lateral edge so that these nerves and vessels are not damaged. And once you've done that, you can go into the prepetroral space, which is being bordered by the posterior surface transabdominis muscle and the fascia transalis and peritoneum. Now, how much lateral or above you can go? Now, the whole mobilization in this plane or TAR mobilization, transverse mobilization, can be extended right up to the midline posterior, up to the psoas muscle posterior. You can go to the psoas muscle posterior, as far posterior. Superiorly, you can go right to the diaphragm, and below you can go up to the pelvis. That is how much mobilization you can do. And this mobilization can give you at least 8 to 12 centimeters of mobilization in the midline unilateral. That means you can have, add this multiplied by 2, you have almost 16 to 24 centimeters of mobilization with the posterior CST combined with the TAR procedure. I think that is all we had to talk about in this edition of applied anatomy, or the surgical anatomy of the abdominal wall, revisited with special reference to the abdominal hernias. And for this and other videos and lectures, which are total number 98, this 99th in the series, you can log on to my YouTube Prime channel, Rajiv Sinha JHS, and please do not forget to subscribe to my channel. Thank you very much.